Good morning. This class we are continuing with our last topic, that is access accidents occur during the cleaning and shaping procedure. And in the cleaning and shaping procedure, we employ a lot of instruments, gadgets, rotary machines, etc. So preferably, clinician must be aware of. Clinician must have a thorough knowledge regarding the anatomy of root canal. And the first and foremost error, or commonest type of error which may come across during the cleaning and shaping procedure is ledge formation. As you can see in the diagram, during the definition, ledge has been created when the working length can no longer be negotiated and the original breakings in the canal is lost. As you can see in the diagram, there is a curvature in the canal. And if the clinician fails to give respect to the anatomy, for example, if the clinician instead of getting a glide path, instead of using a small instrument, if the clinician jump to a larger size stiff instrument, preferably a stainless steel instrument, the stiffer instrument may not be able to follow the pathway of the root canal. It will create its own pathway. So such an additional pathway created by the clinician because of the inadvertent application of a stiff instrument by faulty manipulation or by skipping the instrument from smaller size, we call it as ledge. So ledge has been created when the working length can no longer be negotiated and the original bearings of the canal is lost. Okay, so we can easily minimize and bypass ledge by different techniques proposed. So once the ledge has been happened, then it is very tedious procedure to bypass ledge. So always make sure that the such error should not happen. So as you can see in the first diagram, the ledging and the unnecessary additional pathway created. And if you keep on instrumenting on the ledge, then you may end up in perforation. And the zipping is used in stiff and large instrument. It may cause widening of the apical third and we call it as zipping. And another important error which may occur during the cleaning and shaping procedure is root perforation. Root perforation based on the location of the site of occurrence. Again, site of occurrence, it is again divided into apical, coronal as well as mid-third perforation. And first being apical perforation, as you all know, the apical perforation, the site of occurrence is apical third root. That is preferably at the apical foramen or apical opening, that is called apical foramen. So apical perforation from the apical foramen recording is mainly because of the over instrumentation. Suppose a clinician working length has been marked wrong, okay, because of the misjudgment in working length assessment, it will lead to over instrumentation and opening of the apical foramen and the apical stop or apical series compromised. So apical perforation through the body of the root in the apical third, okay, and even the ledge, if we keep on instrumenting the ledge, it may lead to apical perforation. So another pathway has been created. The main root canal is in the second diagram. You can see the original anatomy is side, whereas the clinician created anatomy is different. So in case of over instrumentation, the correct treatment includes the re-establishing the tooth length short of the original length and then enlarging the canal with large instruments to that length. Okay, so we have to correct, we have to stop till, if the error has already occurred, we have to, so we have to stop there and do not make it further worse. So we have to stop there and we have to re-establish the total length short of the original length and then enlarge the canal with large instruments to the length of the length. And we have to place placement of MTA as apical barrier can prevent restoration of the opposite obstruction material because already apical seal has been gone. So we have to place an MTA as an apical barrier and we have to create an artificial stop and then you can proceed with observation. So in case of an apical perforation through the body of the root in the apical third, try to negotiate the original canal. The mid-root or lateral perforation are basically two types of mid-root perforations. Either direct perforation or strip perforation. Direct perforation nothing but as a result of pressure and force applied to a file during negotiation of ledge canal or through post-space preparation using cutting and burr. Preferably, usually the direct perforation occurs when you keep on instrumenting on the ledge area. You perforate through the side of the root. Whereas strip perforation or second type, that is a stripping perforation, is a lateral perforation which is caused by over instrumentation using files or drills like GG, base freedom, through a thin wall in the root and is more likely to happen on the inside or inner wall of the curved canal, such as a distal inner wall of the mesial root in mandibular first molar. That is the mesial root of the mandibular molar, being it has got a very thin anatomy at the distal wall. So distal wall of the mesial root of the mandibular molar if you over instrument the area, particularly if you, without maintaining the alignment, if you keep on instrumenting at a particular point, you may end up in causing a strip perforation. So this is the diagram which is showing a strip perforation. And so this area of causing this strip perforation we call it as danger zone. Okay, as you can clearly see in the diagram, the more bulk is present, that is called safety zone, and the minimal tooth is present, that is called danger zone. The minimal tooth is usually present in the distal aspect of the mesial canal. So while instrumenting, you have to give respect to the anatomy, and you have to maintain the alignment, and you have to use the proper instrumentation technique correctly. So once the strip perforation has already occurred, the main goal is to instrument and observe the entire root canal system, and the perforation depends surgical and non-surgical using suitable restorative material. So that is the treatment protocol we follow. And all the perforation repairs usually repaired with the help of a restorative material called MTA because of its bio-inducing and biomimicking property. And last perforation, that is called coronal root perforation. So coronal root perforation, again, it could be direct perforation or stripping perforation. Direct perforation happens during access cavity perforation while the operator attempts to locate the canal, whereas stripping perforation happens during the flaring procedure by either eyes or using gaze cleaner. So in older times, gaze cleaner was used to flare the root canal. It could lead to stripping perforation, again thinning of the root canal and stripping perforation. So very utmost care should be taken by the clinician to prevent such errors, and can be prevented if it is similar to what described earlier, the prevention of perforation using access preparation. Careful and conservative flaring, especially when using gaze cleaner, is also recommended. So coming to treatment and prognosis, the repair of a stripping operation in the coronal curve has the poorest long-term prognosis of any type of operation. So when you consider the level of operations, the poor prognosis is often for a stripping operation occurring at the coronal curve. That is mainly because of the inadequate because of the inadequacy in establishing coronal seal. So defect is usually inaccessible for adequate repair. So an attempt should be made to seal the defect internally, even though the prognosis is clouded. So patency of the repair system must be maintained during the repair process. So always try to establish a good seal internally, even though the prognosis is clouded. Then only the prognosis can be cannot judge based on the repair, but we have to try our level best. And there is a promising material to repair almost all types of population. And another important error which may come across during instrumentation is instrument separation. Instrument separation is a nightmare for both the clinicians, you all know that. And etiology could be because of the limited flexibility of instrument. It is a very stiff instrument instead of night type, and overzealous use of application or overuse of instrument. Instrument is subjected to a lot of cyclic load as well as cyclic load as well as tensile. A lot of forces will act on the instruments, especially when you use instrument in the curved canals. Frictional force will be acting on the instrument, and the instrument is rotating in the canal, so cyclic load will be acting. So overuse of instrument may cause fatigue and may lead to fracture of the instrument, and excessive force applied to the files. So someone, if you come across a block inside the canal and if you insert excess force on the instrument to negotiate the block, it could lead to excess force on the instrument and could lead to instrument separation. And again, improper use of instrumentation. For example, if you are inserting instrument mesobuccally, you have to align angle of insertion towards the mesobuccal area. If you are inserting distobuccally, then you have to insert from the mesial aspect. If you are inserting from the parallel, you have to insert from the distal aspect. So that management, that alignment of instrument insertion is also very important. If you cannot use instrument correctly or properly, you could end up in separation. So any instrument can break either stainless steel, night, irrespective of the type of instruments, that is stainless steel, night, and rotary. Any instrument can break in the technique and the manner of use and the proper clinical knowledge and proper tracking of the usage of instruments can minimize the chances of occurrence of instrument separation. So once the error happens, there are basically three approaches. There is attempt to remove the instrument, or attempt to bypass instrument. So attempt to remove the instrument either using small file to bypass instrument and retrieve it, or using ultrasonic tips, or using the specially designed pliers can be used to retrieve or remove the instrument. Second attempt to bypass it, and third one is to prepare an observatory segment coronal to the instrument. So basically there are three protocols to be followed. Either to try to retrieve the instrument if the instrument separation occurs in the coronal third, and if one of the instrument is rotating outside, then you can easily remove the instrument with help of pliers or whatever retrieving instrument. Suppose instrument is in the middle third, then you can even try to bypass instrument. We create an extra pathway for the instrument in the position. It's a small file. Try to bypass instrument. And suppose the instrument tracks out as the apical third and it's exactly at the working length. Then there is no point retrieving instrument because it's already in the apical third, and such cases of no usually occurs when the canal is curved. Okay. So bypassing is always not possible. In such cases, you can prepare an obturator segment foreign to the instrument. So these are the three protocols, treatment protocols to be followed when instrument separation occurs. So operator should attempt to bypass a separate instrument. After bypassing a separate instrument, ultrasonic file process or H files are used to remove the segment. So if the removal of the segment piece is unsuccessful, then the canal is clean, shaped and obturated with smooth working length. If the instrument cannot be bypassed, preparation and obturation should be performed foreign to the level of the fragment. So all this, you can see the diagrams of the separate instrument in the mid road level, and the instrument has been bypassed and obturation is completed. And in the next class we discuss about accidents with the obturation.